Good. All right, everybody. So, as a reminder, my name is Chet Donnelly. I'm a spine surgeon here in my hometown of Dallas, Texas, born and raised. I jump on these lives maybe 20, 30 minutes once every other weekend, once every third weekend, just to go over different things. My disclosure is at any moment I have to run. I have a kid who's napping. The days are few and far between. And when he stops napping, I'll have to find another time to do the lives. So look, here's what I want to talk about today. There's a million different topics of the spine. You can have fractures, back pain, shooting pain. The thing I want to kind of focus on, and then I'll do some Q&A, I'll answer your questions, we'll go over things, is the word spondylolisthesis. That's a big, big, fancy medical word. Let me show you what it means. I'll show you kind of what causes it. There's 6 types. I'm going to focus on 2 of them, and we can talk about what are some of the treatments of spondylolisthesis. Now, is there a cure for that? Cure is like a very debated word. You can fix something. You could have other issues. You could have other reasons causing it. But in terms of fixing that underlying issue, that could be surgical, that can be fusion, that could be non-fusion, could be even disc replacement. Let me show you what that means. So to go into what that topic is, spondylolisthesis, and the reason I even do these videos, the reason I talk about it is because it's a condition I like to fix. It's a condition I like to talk about. Spondylolisthesis, you can have in the cervical spine, but I'm kind of focusing on the lumbar spine, the lower back. It goes bone, disc, okay? Here's the back part. So on the back part of the spine, you have these joints, just like a knee joint. On the left side, on the right side, are these facet joints. And these are the facet joints that move around. They can gap open, facet joints. So spondylolisthesis is just a big, fancy medical word for when one bone is sliding forward on the other. Slide forward on the other, sliding forward on the other. It can be past tense or progressive tense, but it's moving forward on the other. So why does this terminology even matter? Well, let me show you a couple of reasons why. The 2 ways you get spondylolisthesis the most is from the joints having very significant arthritis in the back, or you get a fracture on this part here. So those are the 2 main types. You can get a tumor, a burst fracture. There's 6 like congenital. There's other types of reasons you could get the slip, but most people watching, you probably, if you have it, is either from the degenerative type or the fracture type, the pars fracture. So when it slides forward, it's either from these joints being super arthritic, almost like if normally your fingernails are rubbing on top of each other, it's nice and smooth. Well, it was like sandpaper, like you get a callus formation on your hand. What did we do before we had spine surgeons? Well, God made arthritis to add extra thickened tissue so we didn't wear out our skin and go down to our bone. That's like why you get a callus formation on your heel, a callus formation on your elbow, a callus formation on your hand. That's kind of how you should think about the spine. These bones that are rubbing, they grow extra tissue. If something's inappropriate, something's not feeling good, it grows extra tissue, some wear and tear. You've lost the normal cushion cartilage that hurts, so your body's trying to fuse it, so it's growing extra tissue. That's fine. I kind of say that's not the end of the world. That hurts, but whatever, extra tissue, not the end of the world. Okay, so the reason it does matter, though, at times, is if that extra thickened tissue, it grows into the muscle, that's fine. When it starts growing into the nerve tunnel, that start pinching the nerve, shooting down numbness and tingling, weakness, things like that. Or if you get the fracture in the back, that's not really the arthritis type, but then the bone starts slipping. And there's another type, you get that spondylolisthesis moving. You also get on top of that, this spine model is so hard to use. I have to like squeeze it with all my might. I'm not nearly as strong as I look. I push it down. So you have to kind of come from here. Okay, there you go. So you push it down. You can get a disc herniation on top of all that. So that disc pushes out. There it goes right there. I have to like crank the spine model. See, it comes out. That's a good version of it. Comes out, starts squeezing that nerve, causing the shooting down pain. So, and I promise I'll get some Q&A. A lot of questions coming in. I'm about to jump to it. I apologize. How do we fix the spondylolisthesis? Well, it depends on what type you have. And again, I'm kind of focusing on the degenerative type and the pars fracture type. And there's kind of, in general, different treatments for either type. And it's also, do you need surgery? I'm going to fast forward a little from the do you need surgery, do you not need surgery? We can come back to that later. If you go to my YouTube channel, I have a video called the best treatment or best video on the treatment for spondylolisthesis, I think, something like that. And I go over when you should have surgery, when you should consider non-surgery, things like that. So go look at that video and I can kind of come back to that. In terms of the treatment, it's either if it's surgery. So fast forward, it says surgery. We've done all the non-up stuff, quality of life. Now we're at surgery. So how do we fix it with surgery? There's fusion, non-fusion. Fusion gets a bad reputation, but it really shouldn't. I got a lot of patients out there who are even in this chat, and they might be patients that have fused, and they can tell you, for better or worse, they've had it with others, they had it with me, and things like that. But in general, so I'm reading some of the comments here of some of the followers I have. Fusions are indicated when you have a mobile, that means when you bend forward, it moves, and you bend back, it moves, a mobile spondylolisthesis. That's when fusions are most indicated. If you don't have spondylolisthesis, you might not need a fusion. If it's a stable, like it just kind of moved and it's static there, it doesn't really move that much. It's like move, it's stuck there. You definitely could do a laminectomy. There's even something where I use this ultrasonic bone scalpel and I make an incision about the size of my thumbnail. Like if this is your body, neck, but pretend your lumbar spine, and you're laying down. So if your tissue, your skin's up here, if this is giving you proportion, so this is the size of a pin. So, the skin body's up here. I'm making an incision about the size of my thumbnail. I dilate down, I drop a little tube over that area, bring in a microscope and just kind of use this bone scalpel and just shave away the thickened tissue there. And that's a great treatment for stable spondylolisthesis. When I say stable, it means it's not moving a ton. And I saw a great question coming in. How do you tell if it's mobile? X-rays. Pretty much we always get 4 views of the spine. You get a straight on view. And then if you're orthopedic trained, we also say, hey, I want to see those hip joints because we, from doing hip surgery, have a fantastic understanding of how hip pathology, and I mean hip, I mean ball and socket of your hip, can cause back pain. So it might not even be your spine. It can be your hip. I'd probably say every single day, if not every other clinic day, I'm sending patients to my hip specialist friends, either here in Dallas or in different cities. I got a lot of friends that do hip surgery to get their hips looked at. Because I'm like, hey, your spine doesn't look great, but it's your hip. I promise you, your hip looks terrible. And they're like, well, all the other surgeons I saw didn't say it's the hip. It's like, well, that's because they probably stop at the pelvis and don't look at the hip. Either argument, just make sure your hip joints are in it, because that's a very, very common cause of back pain that goes underdiagnosed. That's the advantage of an orthopedic spine surgeon looking at that sometimes. So once I rule out the hip, the x-rays can look at the straight on view and the side view, and you lean forward and lean back. I can see the mobility. Also, when you have your MRI or CT, you're laying down and seeing if it reduced there, seeing if it's still displaced on your MRI. In terms of the surgery, if it is displaced, that's a very good question. At L5-S1, almost always, and there's many patient factors that go into play on this, gender, age, but in general, almost always at L5-S1, I'll do something called an ALIF, anterior lumbar interbody fusion. That's where a small incision, for real, not too big, not too small. Like if this is the writing utensil, let's say it's about half the size. And you might be at home and be like, mine's that much bigger. Well, that was your access surgeon. I don't know what to tell you, but the access surgeon I use, incision size about that big. And then we go in there, push the stomach contents to the side. They're actually in a sack. Just push them to the side. You have your blood vessels that go down. At 4-5, they drape over. At L5-S1, they split like a goalpost. Just move those to the side. And then clean out that degenerative disc space. If it's not degenerative, then goodness gracious, we're not there doing a fusion, right? Degenerative disc space. If you have that slip, actually, I've done a lot to already reduce the slip. It's kind of not a trade secret. I mean, I tell any surgeon that's willing to listen, but I do this special thing where I put this huge bump under your back. And even when you lay down on the table, I get a lot of correction of that slip just from the patient being asleep. They're paralyzed from medications, like, you're having surgery. You medically paralyzed, just to be clear, lying down, you're fully asleep, sedated, all that stuff. And even that helps reduce it. So then we make that incision. We tunnel down to that L5-S1, or also 4-5, or even 3-4, but usually 5-1, 4-5 is where I do most of my A-lifts. Most of them are 1 or 2 level. Not too common. I do a 3 level, not for I don't want to do it. It's truthfully, most people don't need a 3-level fusion. Most people don't need a 4-level fusion. It's just, you have one area that's worn out, 2 areas, different arguments. That being said, at L5-S1, clean out that area. We put in this very fancy technology. I don't want to say the name of this brand because I'm not trying to advertise for any particular company or anything like that. But this is a very fancy cage. Actually, this is a prototype. So this one, not 100% even out yet. It goes in there just like this. It's got this, let me make sure I'm covering up the name of this company. It's got this fancy mesh you can see. This 3D printed technology. It's got this blade technology, which I'm very keen on. It goes in there, and then I deploy the blades, secures in the bone. Boom. Close that up. Honestly, that takes 45 minutes. We're not rushing, but it's it's like building a car back in the day in the Ford assembly plant. It's all very straightforward stuff. Do it all the time. Sorry, I just killed a mosquito there. We're in Texas, of course, so we got a lot of mosquitoes. Okay, so now that spacer's in there at L5S1, we close that up, move the patient to a stretcher, flip the patient over to their belly, and on the back part of the spine, I'm going to use this spine model. But on the back part of the spine, now I got to stabilize that area. So I make 2 slit incisions, probably the size of this black part of a pin, just to put it in context for viewers at home. And this back part of the pin, I bring in a CT machine, do a spin, and some people don't use navigation. There's a whole pros and cons. The hospital I do most of these surgeries at is the highest volume spine surgery hospital for elective spine surgery in the state of Texas. That's bigger than some countries. So that's a big place, if you can imagine. So no, not TBI. We're Texas Spine Consultants, but it's an independent hospital. It's not, not owned by any facility. We just go to different hospitals that have the good technology. So I go there, do that spin, and then I put on this it is bulky. It's definitely a first generation type of technology. It's a bulky headset, but it's augmented reality. I can see through the patient's skin. And I mean first generation in that, think about the old augmented reality headsets we had with Oculus back in the day. Now we have these smaller things. We have the Meta Ray. So everything gets smaller. It's like the old flat screen TVs in the day. They're flat screen, but their fannies were that big, right? Now we have TVs that are the size of a credit card. So technology will get there in terms of the spine, in terms of making things smaller. On that slit incision, you do something like this. So if you're like, whoa, that's huge, I don't want that. Hold on. Here's your skin. It's this high up. You have your muscle tissue. So through the slit incisions, I can drill, tap, screw. Come to the other side, do the same thing. Test the screws with neuromonitoring, put a little probe on it. They say above 20, 4. I'm just kidding. Above 20. Great. Then you break off these towers. I'm not going to do that because I only have one model here, but you see this is where they break off, kind of right there. That's where they break off right there. And then you're left with just that. And you can see how there's the screws in there. So when people say, I can feel my screws or the screws are causing pain down there, the quick answer is probably not. These are so buried under there. You have all this tissue. You're probably feeling the sutures, the scar tissue and the sutures. These are way under there. You have the spinous processes here. Anyway, different argument. So you get the spacer in there. And why do we do this? Let's go back. Because some people are like, I don't want a fusion. Fine, don't get a fusion. I'm not forcing it. And oh goodness, I was trying to find a different spine model. I swore I have. Okay, well, this is a good one. I don't know. I'm not using this one. So this is the spine. Putting that spacer in there now opens up this nerve tunnel. So you have that height restored. That's a cage kind of falling out in this model. I need to push it forward. There it goes. So you have that spacer in there, and it's opened it up. Before, it was collapsed down. It was squeezing all the nerves in the back. It collapsed down, squeezing all the nerves. So that spacer, the fusion, opens it up. It gives you something called lordosis, curvature back. And then those screws kind of lock it into place. The number 1, 2, 3, 4 questions I get asked is, what's my range of mobility after a fusion? For real, after a 1-level spinal fusion, on most patients, there's no clinical range of motion loss. How is that possible? Well, if we're doing a fusion, almost always, you're pretty much bone on bone already. You're pretty much auto-fused already. And so I'm just breaking open that fusion, putting it into the correct spot, freeing open that nerve, and then refusing into that spot. So, if I did a 1-level fusion on a 15-year-old, obviously they're going to, or not obviously, but probably they're going to have some clinical range of motion loss. There's just not a whole lot of range of motion in the very L5S1 or L4-5 in patients that already have degenerative disc disease and patients that have the fractures, patients that have severe facet joint arthrosis. And that's why we're doing the fusion, because they already have lost it. They've already had that arthritis. It's not this perfect looking spine. If it's a perfect looking spine, my God, why are we talking about it? So let's put a pause on the fusion talk and jump right back to the other non-fusion talk. So in terms of the non-fusion, and again, appreciate the likes and the shares coming through. This helps promote to other people. I see a lot of former patients in all either of these chats. And, I kind of for real say, if you see someone saying they're my patient, maybe direct message them and you guys can talk about spine surgery recovery and experience. I think that's just helpful, not even with me, but just in general. There's so many different spine surgeries out there, 10-level fusion, 1-level fusion, disc replacement, disc fusion. So I think it's helpful just to know that not all are the same and there's different ways to do it. So I do encourage y'all to connect with each other. I think that'd be helpful. Jumping back to another treatment. So again, if you have these stable non-unstable, but stable spondylolisthesis. That's where it's slipped forward, but like it's kind of stuck there. It's so much arthritis in the joint, or it's either already fused, or you can make an argument there's not enough arthritis where it's not totally unstable. You could do something called a laminectomy. Let me show you what a laminectomy is. So laminectomy, if this is the spine, on the back part of the spine, we'll use this L3, L4 example because that's how it was built. On the back part of the spine, you use a shaver and essentially take out this back part of the spine, and now you can clean out all of the nerve tunnels back there. It's a fantastic option. I've done laminectomies L1 to S1. Most of the time it's a 1 level or a 2 level. Now, you can imagine with my social media outreach, I get a lot of people who have seen other videos, and there's definitely videos out there where people are marketing, for better or worse, that a laminectomy is bad for the spine. If you go pay them cash money, they'll do it without taking the lamina off. Fine. Let me really address that. That would be something where you kind of just sneak in between these areas and widen it out and leave the spinous process. That's not totally impossible to do. Oh, that's not totally impossible to do. It's a lot more work and maybe a little less reliable. And sometimes people that are doing that is doing cash pay, which is fine. You know, if you're a famous, successful doctor and you want to not take insurance, then good. Great. Good for you. But the midline sparing, there's a lot of studies I've looked at actually. I'm trying to get this little spacer back in there. The studies that I've looked at midline sparing versus non-midline sparing, there's no difference. There's never been shown to be a statistical difference between revision or anything like that. So I see a lot of people who, on their 10th opinion, they're pretty much going paralyzed, and they're like, oh my God, I just want a midline sparing. That's why I'm reached out to you. And I'm like, for a 1 level, I do it all day, every day. You need 3 levels. You need 4 levels. You have such severe stenosis. They're like, nah, I saw a video. I want midline sparing, no dice doc. And I'm just like hitting my head. I'm like, look, I'm not out there fighting for sick 80-year-old laminectomies, multi-level cases. But I get a little bummed out when people are out there getting 20 opinions, and if they got 9 that all said the same thing, just pick one of those first 9 people and don't go try to find a 10th. So with all that being said, that's what a laminectomy is. Kind of shaving off this back part of the ear. If you have stability, if you don't have instability, it doesn't lead to additional wear and tear breakdown. So it's a great way to take care of the spine. It's a great way to treat neurogenic claudication. It's a great way to treat spinal stenosis without doing a fusion. Laminectomy, outpatient procedure, a little bit based on the number of levels and your age. You know, if you're an old person, if you're from out of state, I keep you overnight. But otherwise, I let people go home. So with all that being said, I've been rambling here for about 20 minutes. Let me answer some specific questions. I'll kind of jump to different platforms here. Apologize for them going through, and I'll just kind of rapid fire these questions. Again, appreciate the likes and shares. That helps promote this to your peers. Wayne saying, I just had an ALIF because of that. Okay, someone else mentioned, you mentioned a laminectomy for my procedure to cure the pain, pinch nerve, but the recovery takes long, right? I say the recovery takes at least 6 weeks. It's not 6 weeks of debilitating pain after laminectomy, but I take off all restrictions by 6 weeks. Most patients are totally better by 6 weeks, some more, some less, but that's just in general. From John, just did my L4-5 fusion with pars fracture yesterday. John, good to see you. Maybe you're in the hospital doing it. From Pilly, happy Saturday, doctor. Nearly missed the live. Pilly, good to see you. From Adam Tubar, I have attended more than 10 vertebral fixation operations. They are wonderful. I love the work, but they do not recommend it to me. I don't know what that means. Yeah, I don't understand your question or the comment. That's all good. Okay, from Pawn Lust. Why don't they teach spine anatomy and biomechanics at school instead of so much about generic advice everyone knows? I don't know. That's a hot take. I'm not really sure. Let me get some of these questions. So from Nori, do you practice biportal, monoportal discectomy? I've done several bipolar cases. I don't hate them, don't love them. I just think the difference with endoscopic spine surgery, which is great, it's an 8mm incision. So we'll try to see what's like a very representative 8mm. Maybe, okay, a screw is usually about 6. This is probably 6 point, this is 6, so it's a little bigger than the screw hole versus 18, probably that big. So let me make this a little easier. I'm being silly here. It's probably the difference between an incision size, the size of my pinky nail, and the size of my thumbnail. That's not my pinky nail, my index finger. But just put context, I can't under my arm. So that's one of the main differences in my patients. Do I want to have incision this big and kind of muck through it, not be able to see everything, have a lot of extra hospital cost. Now, to be totally fair, I don't really care about how much it costs. The hospitals, some of these hospitals make billions of dollars. They can figure it out. I want my patients to do better, but doing an 18 millimeter incision, if you can go find a ruler and see 18 millimeters, that's still pretty darn small, all pretty darn good. From Warren, do I accept Canadian patients? I don't. I apologize. I used to, but truthfully, if I want to get any extra study or injection, it's just such a pain in the butt because of, you guys have such a hard time getting things done, and that's tough for me to have you get an additional injection, additional MRI, and so it's a little unfortunate. From Ellen, degenerative disc disease since 25, now severe stenosis at C5, 6, 7, polyneuropathy. Sorry to hear that. Okay. Trying to read something. What's a way to avoid adjacent segment disease above and below a fusion? Some of it's tough, my friend. Some of it's, I say, look, people ask if I get a fusion L5S1, do I have to get one at 4-5 later? And the answer is probably not. Statistically, probably not. Well, we look at the MRI, and I can just tell you the quality of that disc. Most patients, that's totally good. Sometimes their hospital looks, I was reading a comment. Sometimes their disc above already looks bad. And I tell them, I'm like, look, we don't need to fix this one today. Maybe it needs to fix in 10, 15 years. Well, goodness, maybe World War III is in 2 weeks. Maybe it's in 2 years. Maybe there's COVID. Maybe there's a car wreck. Who knows what things that can happen in life. We'll figure out that 4-5 issue if that ever pops up. But that's not necessarily because you got the L5 surgery that you need the other one. The reason you got the L5S1 surgery in the first place is because of this degenerative disc disease. It's not isolated to that one level. It definitely could be going on at this level too. It could be going on all your joints. A lot of my patients had issues, oh, I've had an elbow replacement, I've had a shoulder replacement, now it's a spine. It's like, well, it's not the spine, it's a degenerative disc disease. Let me get to a couple questions. Do I know anyone good in San Antonio? I know one guy, I think he's pretty good, Antonio Webb. We're kind of buddies. That's the only one I know there. I know a couple of neurosurgeons there I don't recommend, but I do know a spine surgeon there I definitely recommend. But I'll say come up and see me, and I'm not too far away. Do I know anyone in Austin? Yep, one of my buddies, Rory Mayer, is in Austin. He's a good guy. He's a neurosurgeon. I think he's the absolute man. From Nori Ferrona, do you prefer transforaminal or interlaminar? Okay, there's some good questions here. Transforaminal or interlaminar for the injection? Is that for an injection? I prefer intralaminar. Sorry, transforaminal for the injections. Let me get to a couple things. I have terrible lateral shift for my herniated disc, L5S1, for months. Can this be fixed? Does it need surgery? I have a couple videos, Reggie, about does this condition need surgery or not. It's more about quality of life, kind of what you're going through, what your motor strength is. A little hard to say. I had a partial discectomy, L5S1. I'm 32, starting to have the severe pain again. Well, it sounds like you made it for 15 years. That's great. Maybe you have another issue at another level. Hard to say. Can you describe, I just saw a big word, pseudoarthrosis. Pseudoarthrosis means you got a fusion in terms of the rods and screws, but the joints didn't fuse. So you have these joints in the back here. Let me use this model. The clear model is a little hard to show you, but these joints didn't fuse. So you kind of try to decorticate and get the joints. But also in modern spine surgery, we put spacers in here, cages. Now we didn't, pretty much for every level it gets fused, we put in a spacer or a cage. That wasn't the case even 15 years ago. And there's definitely some patients where we just put the screws in. We don't put a cage in here. That's usually older patients, sicker patients. But in general, we put a cage for every patient because we want this disc space to fuse. So when you hear about someone that got a fusion in 2002 and they didn't fuse, well, we're still finding newer technologies, safer ways to get to the disc space. Now we put these spacers in. Now we have different bone graft material that's more cost efficient, more able to mass produce, more able to get into our hands better. And we get the disc space to fuse. And that's a big part of the fusion. In fact, I'm relying on the cage to fuse more than anything else. So when someone talks about they didn't get a fusion, that's not incredibly rare. It depends what the surgery is, the patient's biologics, but that's what pseudoarthrosis is. It's like it tried to fuse, pseudo, but it didn't fuse, arthrosis. Let me see this nice question from Jonah Reed. Sorry, there's about 1,000 people in these chats. They're coming across. I'm trying to get to them, but you can imagine they come across. I saw my favorite topic, pars fracture. It says L5S1. They keep texting. I keep missing it. For bilateral pars, didn't fuse past 18 months. Is that common? 18 months is definitely at the rate where it's now you would expect it to have heard. So bummer that your L5S1 A-lift didn't fuse. You know, A-lifts actually have a much higher, not much, they have a higher, I don't know if I can go on the record saying much higher fusion rate, but at L5S1 for a pars fracture, I don't know if I can say gold standard, but there's definitely high level evidence from a great surgeon named Andrew Simpson when he was at Brigham Young, not Brigham Young, sorry, Beth Israel, goodness gracious, Beth Israel, that showed doing a fusion here at L5S1. No, not at Beth Israel. Goodness, I'm being such an idiot right now. He was at Harvard, but well, whatever, in Boston. I'm totally blanking on the name. L5S1, doing an A-lift here, putting in the spacer in the back here, and putting in the screws in the back is the gold standard for pars fracture L5S1 in terms of having higher patient reported outcomes, higher restoration of disc space, higher restoration of lordosis. It's not Brigham Young, not women's children's. Gosh, someone surely in this chat's from Boston can tell me the name of the hospital. I'm being totally blank what the name of that hospital is. Not Brigham Young, not women's. Anyway, one of the famous hospitals. Yeah, Brigham Women's. Okay, Brigham and Women's. Yeah, okay. I was like, not Brigham Young. Sorry, college football is on my mind. It's close to being close for college football to start back up. So we're a big hockey family. Hockey's finally over, somewhat, thank God. And yeah, Brigham and Women. Goodness, I was Brigham Young. That's almost comical, actually. All right, so let me get to a couple other questions. Appreciate coming in. I do have to run. If everyone hangs on, I just need to check my text really quick. No one leave. Okay, just looking at a couple of things here. Here's a good question. Why don't more ortho recommend disc replacement over a fusion where you lose mobility? Well, I recommend disc replacement when I think that there's a chance of a good outcome. Let me tell you what I mean by that. So I would first think about it in terms of totally think about the neck differently than the lower back. It's almost like you shouldn't really compare a hip replacement to a knee replacement. Now at home, that all we're like, duh, that makes sense, right? A hip replacement's different than a knee replacement. Yes. And I know that makes sense. And maybe people don't compare them, but you shouldn't compare a disc replacement in the neck to a disc replacement in the lower back. They're two totally different things. They have the same words for the most part, but they're totally different. In the neck, for the most part, every spine surgeon, and that's not like a fair statement, but the majority of spine surgeons like disc replacements in the neck. That being said, I do way more fusions than disc replacements in the neck. And that's not because I don't really know what the reason because, but the reason is because just the indications. When I see a patient that maybe travels from out of state or wants a disc replacement in the neck, I know I could earn their business, for real by giving them what they want, but I have to instead offer them what they need. This is a 2-level, so just kind of get rid of one. A 1-level neck fusion, a 2-level neck fusion, even sometimes 3-level have good outcomes, and that's what you need for many, many pathologies. I have many videos discussing, even me giving podium talks about who's a good neck replacement, disc replacement in the neck versus fusion in the neck. And that's thing number one to think about. Just because I can do a disc replacement doesn't mean it's the best thing for you. Maybe a fusion is the best thing for you. So it really depends on the x-rays, the clinical exam. So that being said, why don't more doctors do disc replacements? I think in the neck, we like disc replacements in the neck. They're good. There's advantages. To be fair, a 1-level disc replacement in the neck and a 1-level fusion in the neck are pretty equivalent. They start to get different results when you get to the 2 levels. The thing that's a little tricky, if there is a 3-level case, that insurance doesn't approve 3 levels, and that sucks. So then the patient has to pay cash for the 3rd level. I have a lot of mixed thoughts on that, but I also usually say it's not normally indicated to need 3-level pathology. And if you have a 3-level pathology, it's from severe wear and tear. And if you have severe wear and tear, you should be doing a fusion, not a disc replacement. So that's not all 100% true, but that's kind of a way to think about it. So moving on from the neck, going to the lower back in terms of the lumbar spine, doing disc replacements in the lumbar spine. So here's a model of that. Here's a 2-level disc replacement model. That's where you get, I'm just going to move this so it's just a 1 so I can hold it a little easier. Here's a 1-level disc replacement in the lumbar spine. That's where you get to a tad more controversy, where some doctors either are like, no, there's so many, it's one of those things like intraoperatively in the first couple of weeks, you're probably going to do fine. I think most surgeons are thinking about how do we fix an issue if it comes up 6 weeks later, 6 months later, 6 years later with a disc replacement. And the neck, very easy to bail out, to get that out, to fix it. Indications if it doesn't work. And the neck, it's very easy to fix. Big overstatement, but in general, easy to fix. Lumbar spine's totally different. In the lumbar spine, there's a lot more thought on the biomechanics in terms of your where your spine lives, where your shoulders live in relation to your lower back, in terms of called pelvic alignment. And there's a big appropriate school of thought that's saying a fusion. So putting in this spacer that's fat in the front, skinny in the back, is way better for doing spinal alignment fixing, and that is way better for back pain, way better for future surgeries. Fine. The school of thought says these disc replacements don't do that nearly as well. I'm not getting into that debate, but I'm saying that's where the debate comes from. And then there's a debate on, well, fine, what about L5S1 versus L4L5? And there are some spine surgeons out there that say, oh, I'd only do a disc replacement at L5S1, but not at 4-5. And then there's some that say, well, the pelvic alignment, I would not do a fusion at 5-1. I would only do it at L4L5. So now you're at home being like, what in the actual heck is this guy talking about? I'm so confused. And welcome to the club. And that's where a lot of the debate is. I will say one of the most dangerous surgeries that hopefully I never have to do is taking out a lumbar disc replacement from L4, L5. It's a revision surgery. That's where your blood vessels are going over the front here. And at 5-1, they split like a goalpost. So pretty hairy, but not crazy. At 4-5, super hairy. Tons of blood loss. Definitely a risk of death. And so if you have to take out a disc replacement at L4-5, you could die. And we'll see how my career goes, but I don't plan on ever doing a disc replacement at 4-5 because I don't want to be the one responsible for potentially, even if it's less than 1% chance they ever need that fixed, that less than 1% chance of, making someone a widow or something like that. So I don't plan on ever doing it at 4-5. Again, technology could change, different ways to put it in, all this stuff. So it's 2025. Maybe this video doesn't age well. We'll see. But in general, that's that might get to your question. Why are some people hesitant? Well, hopefully that just answered a lot of it. So I'm a little exhausted from all that. I'm looking at a couple things here in terms of my timeline. We've been doing this for about 30 minutes. I'll just kind of take questions now. I'm a little worn out. I got a couple things I need to get done here in this downtime I have. My kids are napping. Do I keep talking on this? Well, let me actually kind of close it up. I do have a couple admin stuff and things I need to do to continue on the day. I see questions coming in, but we're kind of at the 30-minute mark. I'm losing steam here. Let me just kind of summarize it with two more things. Talk about spondylolisthesis. Is there a cure? Is there not a cure? Well, I don't know if cure is the best word. It's something where if you have spondylolisthesis at L4, L5, L1, for sure, and it's unstable, you failed conservative treatment options, all that stuff, for sure, putting a spacer here will open up these nerve tunnels just like this. And then you put the pedicle screws in the back to stabilize it so that it gives the fusion support here. This is a model I like to use. Again, I'm not going to advertise the company, but you can even see how when you put in that spacer, it opens it up. Great. So that's the indication for a fusion. Total disability with quality of life, nerves being pinched, bone on bone, your back is kind of hunched forward from the collapse, you have instability. That's what our surgeon, either from the side, called a lateral, from the back, called a T-lift or PLIF, or from the front, called an A-lift, which I love, will put in those spacers like this. In terms of why do I love A-lifts, not just for this condition, but for any time I do a fusion, well, A-lifts have a huge advantage in terms of the spacer you use. So if you think about the different spacers, let me just show you an example here. This is an A-lift cage. It's big, bulky, and that's great. This, oops, that's an ACDF cage. That'd be fake news. This is a PLIF cage. So look at the size difference. Some people don't have, you have to have an access surgeon that goes in and does the anterior exposure. Some cities, some university hospitals don't have access reliably to an A-lift surgeon, or the access surgeon. And because of that, they, they'll do this cage. That's fine. I'm not poo-pooing that. Or they have a surgery center and they don't, want to go through your belly at a surgery center. They want to do this at an outpatient surgery center, which is fine. For real, I'm not criticizing that. I don't have a surgery center. If I did, maybe I'd do them at a surgery center. So because I don't, I do a lot more of the A-lifts. The advantage is it's a fat in the front, skinny in the back compared to this. You're like, well, why can't you just put this fat cage in from the back? Well, as you can imagine, these nerves in the back, I can't get in this big fat cage through those nerves. My goodness, it would rip through it all. But if you go through the front, you can put that here. So if you go through the front, you get this cage in here. So that's when you're laying down on the bed and it goes in through the front, right through here. And that's a huge advantage of an anterior approach. You get the height, you get the curve back, you get the footprint. So you get all this fusion material. Whereas if you do it all from the back, this is cute. Many of my buddies, most of my buddies do this. And I'm not going to tease them. It's just different practice patterns. They don't have an access surgeon, or there's only one access surgeon in town, and they're old, slow, not always available. But then also when you go through the front, you can put these things in. They have a screw that go through it, and then you have an extra point of fixation. The screw goes in there and holds it into place. So I'm not here trying to advertise for A-lift surgery. I'm not here trying to criticize those that don't do A-lift surgery. It's not really a debate. I think no one, they'd be like, I wish I had an access surgeon like you guys do in Dallas. My God, I'd do them all day. And that's what we get to do. So with all that being said, fusion is not a requirement for, just because you have spondylolisthesis doesn't mean you need surgery. Just because you have spondylolisthesis doesn't mean you need a fusion. There are 6 types of spondylolisthesis. One of them, if it needs surgery, definitely needs a fusion. One of them, if it needs a fusion, definitely needs screws in the back, spacer in the front. It's a 360-degree fusion surgery. And there's other types that maybe don't even need to have surgery and maybe don't even have a fusion. That'd be ones that are fixed with a laminectomy, doing a minimally invasive thing where you just open up the nerve tunnels in the back. A great procedure. You can do this midline sparing where you keep the midline aspect and clean it out. So there's a lot of ways to fix different conditions. And I just encourage you to watch some of the other videos I have out there, be educated so that when you're talking to your spine surgeon or your pain management doctor, you just know the different options, and then being educated, you can be a better advocate for yourself. It'd be like, I can't think of a good analogy. It'd be like if you're doing taxes and maybe having that conversation with your accountant, you can help them see things that maybe they didn't see, or maybe if you knew all about your taxes, you could find advantages that are allowed to you. I'm terrible at taxes. I don't do anything. I just say, tell me what it is. So I don't practice what I preach on that in terms of watching videos of accounting, but maybe there's not someone out there doing what I'm doing here, and I'd benefit if someone told me if there was, but I probably still wouldn't watch it. It would sound pretty boring to me. All right. So with that, everyone, I'm going to sign off. Appreciate it. Just as a reminder, I'm a spine surgeon here in Dallas, Texas. I was born and raised here, downtown Baylor. So I'm homegrown, kind of never moving. My family's from here. My wife's from here. Our kids are from here. And Dallas is near and dear and home. I'm in a 6-person spine surgery group. I'm very fortunate and blessed that we're still somehow private practice, not hospital owned or university employed. So we are allowed to kind of go to different facilities. We're not really owned by any specific institution that tells us where we have to go. The advantage is that means I can go to different hospitals that offer the best technologies, and I can pass on my patients. So with all that being said, you can always direct message me. I can get you additional questions. Can't give you any specific medical advice, but connect you to my peers. Please share this to your peers that might be having the same thing. And then I usually end all these by signing off here. I'll spend 2 minutes right here to kind of, if you tell me what city you're from, I'll tell you if I know a doctor in your area, but I won't do that here because it's recorded, and I don't want to get in trouble if I don't say a certain doctor's name. So